Good evening, everyone. I'm Dr. Midhun Mohan, faculty in emergency medicine and critical care from Doctor Tutorials. All right. Uh, Dear residents, we are going to discuss something which is very important. All right. During your residency, how you can make the most out of emergency medicine as well as ICU postings. Okay. Now, now especially because there is a separate specialty called emergency medicine, and we have DM in critical care also in many of the institutes. The exposure for medicine residents cases as well as ICU cases is much less. That's a fact. All right. And over the years, it's going to be over the coming years, it's going to be very much on the downside. All right. Now the trend also is that medicine residents, they think it's not an important posting, especially in the emergency department. All right. Many of them prefer the ICU postings. They like the ICU postings because they want to. Sometimes a lot of them want to go into this critical care specialty. So they want to go through the NEET SS for critical care or INI SS for critical care and want to take up this specialty. So all of them are interested in ICU postings, but they generally have a trend to disregard the importance of the emergency department posting. All right. But this is something which every doctor, emergency care is something which every doctor should be knowledgeable about. And there are certain skills which you have to learn from the emergency department, which will be valuable throughout your practice. All right. Even if after becoming a physician, you will be trying to see cases, stable cases in your OPDs or in your private practice. Still, when you have some kind of emergency, uh, let it be even, let's hope not, even at your home, you are expected as a doctor to treat these patients or treat your relatives even. All right. So emergency care is something which every doctor should be knowledgeable about, and certain skills like doing CPR, uh, uh, giving rescue breaths, then how to manage certain injuries. Those things are extremely important, even if you are going into a different specialty. All right. So uh, I am currently working in a hospital which runs a DNB program for both emergency medicine as well as general medicine. All right. One of the things that the general medicines residents, they keep on saying is that they don't say directly to me, but they tell emergency residents that uh, nowhere else general medicine residents are being posted in the emergency department. Even today I heard that. All right. So I had to go through the curriculum of medicine residency program in both NMC as well as national board. And the and what they are saying is kind of correct, because the NMC as well as the national board, they do not recommend any special rotations, but they what they actually recommend is the areas in which the residents should be knowledgeable about. All right. And in that, emergency care as well as critical care is it's of very prime importance. Okay. So if you look at this is the NMC curriculum for medicine residency. You can see that in the second year emergency care, the content should include emergency care and specialized procedural skills. Okay. And the residents should be capable of taking independent duties. All right. See, whenever you are taking duties, especially the night shifts in your ward or wherever you are being posted, one of the things that you are expected is to know how to handle any emergencies, because during night time they would be calling you, only to handle these kind of emergencies. All right. So emergencies can happen anywhere at any time. So whether it be in the ward, or sometimes the patient in your OPD can go into cardiac arrest, sudden cardiac arrest, or even they may have a seizure. All right. So you need to know how to handle all these cases. Any kind of emergency, at least the initial steps till you can bring the patient to the emergency department. All right. Or shift the patient to the ICU, because every second counts whenever there is an emergency. What defines something as an emergency itself is time. All right. Time that the patient has till he goes into cardiac arrest, or the time from cardiac arrest till we declare the patient as death. It's just a matter of few minutes or few seconds where your intervention, for that time, if you intervene promptly, you may be able to save that patient's life. All right. So time is something which is very important, and emergencies can happen anywhere, anytime. All right. And you cannot say that you have not been trained to handle these kind of things. Okay. It's something which we are supposed to learn even during our MBBS days, but unfortunately, in our curriculum, not much is given for emergency care. All right. MBBS students are being taught how to take stable cases in the wards only, and in the casualty posting, which earlier we all used to have, they are taught how to handle certain procedures, do certain procedures like suturing, those minor things only. All right. Uh, Earlier, emergency medicine used to be a NMC had made mandatory that emergency medicine should be a part of teaching of undergraduate students. But now, because of the lack of emergency medicine faculty, they have actually withdrawn that mandate. All right. So emergency medicine is not currently a mandatory specialty posting for undergraduate students. All right. So most of us, even after becoming doctors, we are not capable of handling many of the emergencies. All right. So during your residency program, especially medicine residency program, this is the time where you need to focus on acquiring certain skills to handle or to save a patient's life. All right. Okay. And here you can see in the second year, you are supposed to learn all kinds of procedures, respiratory management abilities, then communication skill. This is something extremely important in the emergency department, or earlier we used to call it as casualty. Now, if you look at any violence happening against doctors, most of it happens in the emergency department or casualties, or in the ICUs, because much more it's in the emergency department compared to the ICUs, because that's where things happen very unexpectedly. All right. Patients bring in patients, bystanders bring in their relatives who are patients in a very sick condition, and you have very little time to react and save that patient's life. But many a times, it may not be possible to save every patient's life if they are coming either too sick or not responding to your treatment. A lot of patients die in the emergency department. All right. And if you don't have a good communication skill to communicate properly and to provide adequate grieving time for the relatives, then this is one of the reasons why many of these violences happen in the emergency department. All right. So communication skill is something which you have to learn from experts, from your teachers, who knows how to handle these kind of things in the casualty or emergency department. And it's something which you have to learn by practicing also. All right. So emergency department posting is extremely important. And any skill, see, all procedures you can learn only by doing it. You have to watch it, you have to see one, you have to do one, and you have to teach one. That's how you master any skill. Right. Okay. Now in your third year, again, special skills, which include even ICD insertion or tube thoracostomy, intensive critical care. Those things are usually ICU postings, especially. You have to acquire those skills, especially during your final year. All right. Now, one of the things which I have seen is that See, I used to work I used to do my residency in a casualty setup in Government Medical College, Calicut. All right. At that time, the first batch in emergency medicine there, in emergency medicine residency there, and we were still having a casualty setup. All department residents would be there: medicine residents, surgery residents, and ortho residents. Every department will be there within the emergency department itself. All right. And what I have seen that whenever a patient is having a pneumothorax, the medicine residents were not able to put an ICD in. They had to wait. They had to sometimes even beg the surgery residents to come there and put the ICD in. All right. So surgery residents like they are the masters of this thing, and they would do the procedure. It's a very simple procedure. Thoracostomy is a very simple, which every in which every doctor should be able to become heroes. So these are skills which a medicine resident should be absolutely knowledgeable about. They should be able to do the procedures like tube thoracostomy anywhere. All right. Now, if you look at the National Board Curriculum for General Medicine residents, you can see from critical care and emergency medicine, you are expected to learn evaluation and management of acute respiratory, cardiac, renal, and hepatic failure, shock and cardiac arrest, neurological critical care, evaluation and management of comatose patients, ventilation strategies, evaluation and management of shock. All right. Now, if you go a bit more, you can see that poisoning, drug overdose, envenomation. These all patients present to the emergency department first. All right, there is no point of treating seeing them only after the emergency department has made the initial diagnosis after the resuscitation. There is no point of seeing these patients only in the wards. When you're doing residency, you need to see these patients upfront in the emergency department itself. All right. Then snake bite cases, mammalian bites, then environmental emergencies like altitude illnesses, hypothermia, heat stroke. All these things you should be able to learn from the emergency department. Now, this is a bit in detail. The national board actually gives much more in detail regarding what all skills you have to acquire during your residency program. All right, and you can see here in the practical skills, airway management is extremely important, especially intubation. Then how to do cricothyroidotomy, tracheostomy, even tubothoracostomy. You see here for a tension pneumothorax cases, you need to be able to manage by putting a needle in as well as an ICD in. All right. Then mechanical ventilation, including a range of ventilatory modes and strategies, which you can start learning from the emergency department, and much more in depth you learn from the ICUs. Then hemodynamic techniques like arterial catheter insertion, blood gas sampling, central venous access, venous cut down, renal replacement therapy. Then diagnostic and therapeutic procedures like control of epistaxis, peritoneal tap and lavage, lumbar puncture, pericardiocentesis. All right. I'm not sure if all of you have even got a chance to do pericardiocentesis or even watch pericardiocentesis. All right. So it all depends on where you are currently doing your residency. All right. uh, in if you are doing your residency in a major institute or in a major government medical college, mostly you are still having a casualty setup. All right. The emergency department may not be under the control of the department of emergency medicine. Okay. There is a difference. All right. So if the department of emergency medicine is doing the administrative role of the emergency department, things will be much more organized, I would say. All right. Now, many of you might be still working in a casualty setup where all departments are still there working as independent units. So medicine residents will be sitting in one place, surgical residents will be sitting at another place, then ortho residents will be sitting at another place, and the patient has to be moved from each of these departments whenever they have a single patient can have medical problems, surgical problems, as well as orthopedic problems. So the patient will have to move from one department to the other department to the other department, and it's not very good. All right, because any patient coming with any disease, we have to treat the patient as a whole. All right, that's the concept of emergency medicine. Okay, so it all depends on where you are currently doing your residency program. And if in government medical college, in government medical colleges, you'll be getting adequate exposure to all these kinds of cases. All right. But if you are doing especially DNP program in private hospitals, especially if there is a proper emergency department there, which is run by the Department of Emergency Medicine, and they have DNB emergency medicine residents also, then your hands-on exposure will be much less. You will have to put in extra effort in the department, develop a good rapport with the emergency medicine department, and try to get more hands-on from there. All right, as well as this goes the same in the ICU also, because many of these private hospital ICUs, they might be running different intensive care courses like IDCCM or even DRNB in critical care, and they will be having their own residents doing the usual work there. All right, and you are kind of a guest there, and you have to develop a good rapport with these departments to get these hands on. All right, and it's very important that there is a good rapport between the departments itself, between the faculty of these departments. All right, then only they will be able to make sure that you will get adequate exposure during your residency time. All right. Now, I was talking about where I did my residency. I did my undergraduate postings as well as postgraduate uh, residency in emergency medicine from Government Medical College, Kozhikode. And you can see this was the casualty setup at that time. It has changed a lot now. We have a proper emergency department now at Calicut Medical College. And this is a picture of the triage at that time. You cannot identify who is the bystander here or who is the patient here, and you cannot even see the doctors or nurses there. All right, so there was a lot of chaos there. This is because of the crowding there. All right, and you can see this is the medicine side. The medicine doctors would be sitting here, and they will be surrounded by bystanders. I'm pretty sure that a lot of you can relate to this if you are especially working in a government medical college. Okay, you see that all these are not patients actually; these are all bystanders. All right, the patients will be somewhere behind here, and there is no one actually monitoring these patients. Okay, so the care the patients get is actually really compromised in a crowded casualty setup like this. That's why now we have proper emergency medicine department which controls the entire casualty. Now it's called the emergency department. Okay, here the problem is that there is no single ownership of this department. All right, if you don't have a proper department of emergency medicine, so medicine people will be taking care of their own things, surgery residents and surgery faculty will be taking of their own things only, but nobody actually cares about the development of the department, the casualty as such. All right, whatever is there available is there, they will make use of it, and the patients will be suffering with that. Okay, now this is the surgical side, and this was the ortho side. All right, and this was the radiology side. You can see head injury patients lying there without any monitoring and waiting for the CT scans to be done. Okay, you cannot find any single doctor or nurse there accompanying these patients. All right, that's the scenario in government medical colleges. Okay, so when you're working in the emergency department, it's going to be a different environment. It's going to be a different ball game. All right, the main difference from OPDs is that, see, in OPDs you have to see patients one after the other only, and you know that these are relatively stable patients. But in the emergency department, it's very unpredictable. You can get unpredictable number of cases sometimes. uh, See, in a government medical college code, every day we used to get about 800 to 1000 patients. all right, and excluding pediatrics and gynecology. Okay, but some days you might get 500 patients. Okay, and if you're working in a private hospital, this number will be much reduced. You might be seeing about 50 patients or 100 patients in your emergency department. All right. Now, unpredictable type of cases. Some patients are really sick, some patients, because emergency department is open to all patients. Okay, you cannot refuse care in the emergency department. Any patient can come to the emergency department. All right, and some so it's a very important skill to acquire to differentiate a sick patient from a not so sick patient. All right, uh, I have seen house surgeons as well as first year PGs, even after a patient is brought in cardiac arrest, they are not able to even identify that. They keep on taking the history. So the approach in emergency department is entirely different from what you learn during your undergraduate days, as well as during your residency in medicine. All right, because time is very critical here. So when you have a patient in cardiac arrest or in respiratory failure, you need to act quickly. You need to do or intervene immediately rather than taking the history first, arriving at a diagnosis, and then only if you wait to provide the treatment. By the time you start the treatment, the patient will become just part of your history. All right, there won't be anything else to take care of. Okay, so it's very important that you have a different approach in the emergency department. We usually follow something called as the ACLS survey, or if you have a trauma case, we follow something called as ATLS survey, where you have something called as a primary survey followed by the secondary survey, where you look for life threatening conditions in the primary survey. You intervene, you do whatever is needed to save that patient's life first, and then only the detailed history taking is done. All right, and then only the complete physical examination is done in the secondary survey. All right, so time is very critical in the emergency department, and you need to learn this approach. And how to intervene very quickly is by recognizing the emergency in that critically ill patient. All right, and this comes with experience, so you need to spend a lot of time in the emergency department. Try and see as many sick patients as possible. All right, the other thing about the emergency department is that it usually has unrestricted access to even the bystanders, especially in government medical colleges. All right, so that's one of the reason why we have a lot of violence taking place in the emergency department. It's very hard to control the number of bystanders coming with a single patient. Okay, then we have to take care of multiple patients at the same time with varying demands. All right, so it's not like in OPD where you evaluate one patient, make the diagnosis, dispose that patient, then only you see the next patient. It's not like that. Throughout the day, patients will be coming in. All right, some patients might be there for 4 to 6 hours. Some patient might have just come in. You have to take care of all these patients at the same time. All right, and the requirements or the treatment needs of all these patients are entirely different. Investigation wise, observation wise, consultation wise, treatment wise, it's entirely different. Okay, so at the same time you need to manage all these demands. All right, that's a different skill. Now, I already mentioned about bystanders. Sometimes most of these bystanders are anxious. Sometimes they may be intoxicated, and their attitude might be really bad towards you. Almost unrestricted access will be there for many of these people. And emergency department is also a dependent specialty. This is something which you need to very well understand. All right. See, emergency departments usually do not admit patients under them. All right, so I, even though I admit patients, I do not admit patients under my department. I admit patients under the medicine department or surgery department or ortho department or some other super specialty department. And because the further care has to be carried out by these departments. All right, that in that way we are kind of a dependent specialty. Okay, this is very important to understand. All right, and we to admit a patient, we need to have ward beds or ICU beds. We might have to ask for consultations from other departments and other staff. Okay, so that's why we are said to be a dependent specialty. At the same time, the emergency department should also be a dependable specialty, because all these other departments will get cases. Majority of the admissions come through the emergency department. All right, and once these patients are admitted to the ward, it is assumed that the emergency medicine department has already resuscitated, made a provisional diagnosis, ruled out life-threatening one, and the patient is relatively stable to be admitted to the ward. All right. Or if the patient is admitted to the ICU, that means the emergency department has identified a life-threatening condition, and this patient requires an ICU care. Okay. So emergency department should also be a dependable specialty. Now, the problems in emergency to understand, we have a fixed space, fixed number of beds in the emergency department, fixed number of beds in the hospital. That's also a major problem, because if you want to admit a patient and you do not have enough beds in the hospital, those patients will also remain in the emergency department, creating the crowd. If you remember the pictures, the photos which I have showed, the problem is that many of these departments there, they keep the patients there overnight. All right, even when they are stable to be shifted to the ward, sometimes they keep the patients in the casualty for a long period of time, which is a reason for a lot of this crowding. All right, crowding is a major problem. It can lead to poor patient bystander satisfaction, which can lead to violence. It can lead to poor healthcare professional satisfaction also. We might not be able to do things properly. It can lead to a lot of errors. It can lead to negligence from our part. So we always have to try to avoid crowding in the emergency department. And this is something which every other department should acknowledge, because sometimes when you call for consultation from the other departments, they might take many hours. They want to finish their work in their own department, and then only they come to the emergency department. The problem is that we have fixed number of beds in the emergency department, and patients keep on coming in the emergency department. New patients will always keep on coming. All right, and we have to keep on freeing up the beds. Okay, so there should be a continuous flow of patients through the emergency department. And because we are dependent, emergency department is dependent on other specialties also have to acknowledge this issue, and they have to help out to carry out the work and move the patients quickly through the emergency department. All right, so when an emergency medicine resident or someone calls you for consultation, try to see the consultations as early as possible, and try to avoid delay of more than at least 1 hour. All right, try to see the patients as quickly as possible. Okay, now when you're working in the emergency department during your rotations, this is something which you need to keep in mind. What are your roles and responsibilities in the emergency department? All right, first of all, identify or even rule out life threatening conditions. Okay, that's what is expected from you in the emergency department. About 60 or even 70% of the patients coming to the emergency department might be absolutely stable patients. Sometimes you wonder why this patient has come even to the emergency department. He could have gone to the another PHC or CHC, or maybe come the next day to the OPD. All right, but we cannot refuse care in the emergency department. That's the problem. Okay, so a lot of these patients come, even stable patients come to the emergency department, and from that lot you need to identify those patients who are having life threatening conditions. Okay, now if this is not a simple thing. All right, so if a patient comes with chest pain and you are saying that this is not ACS, acute coronary syndrome, and you are discharging this patient home, you have to have the knowledge as well as the skills to how to evaluate a patient with chest pain, read ECGs, even do point of care ultrasonography, echocardiography to rule out aortic dissection or ACS. Then those kind of things, it's not very simple. You need to acquire that from the emergency department itself. Then resuscitation, emergency physicians as well as intensivists are expected to be the resuscitation specialists. All right, so your job is to make the patient stable, okay, or at least initiate the resuscitation and carry out the further resuscitation from the ICU. All right. Then symptomatic relief, it's extremely important. Whenever somebody comes with pain, doesn't matter the underlying diagnosis. The patient wants relief from that pain. Do not ever forget that. All right. So symptomatic relief is absolutely important even before you make a complete diagnosis. All right. Then diagnosis, especially of life-threatening conditions or ruling out these life-threatening conditions, has to be done from the emergency department itself. All right. But many a time in some of the cases, you might not be able to make a definitive diagnosis. All right. For example, it might require further investigations like imaging, or it might require many other investigations which are not available in the emergency department or during the night shift, like hormonal assays or those kind of things. Okay. Or some investigation reports might come only later. All right. So it's not always essential to make a definitive diagnosis from the emergency department itself. All right. This is one thing which you need to understand, because if a patient requires admission for further evaluation, you can admit the patient and shift the patient to the ward. Huh? Okay. Don't wait till you make a definitive diagnosis in the emergency department. Your main role is to rule out life threatening ones and determine whether this patient requires admission for further evaluation, or you can dispose this patient and follow up in the OPD. All right. Now, flow management is what I mentioned. This is very important to prevent crowding in the emergency department. Crowding is a major problem. Okay. So, flow management, this is something which everyone should keep in their mind. All right. Patients should come in, patients will keep on coming in. Whatever that has to be done in the emergency department should be done there. And these patients has to be disposed of. All right. Either discharged, or they should be admitted to the ward or to the ICU. Okay, so disposition is also very important, and that's a skill which you need to learn. Well, suppose if a patient who is really sick requires ICU care, you are wrongly admitting them to the ward. That's a major problem. This patient wouldn't get adequate care in the ward. All right. There will be multiple patients, there will be less staff there to take care of these patients, and the patient's condition can deteriorate in the ward. Now, on the other hand, suppose a patient who is relatively stable, you are wrongly admitting to the ICU. An ICU bed will be occupied by a relatively stable patient. Okay, and a patient who actually deserves an ICU bed may not get that bed. Okay, because beds are completely occupied. Okay, so flow management as well as disposition is extremely important, and timely consultation, and every department who is involved in emergency care, they should have flow management in their mind. All right. Now, documentation, I don't have to mention the importance of this. Really important, whether you are working in the emergency department, ICU, or any other department. All right. Now, facilitate care and working as holding area. This is what I mentioned. Suppose if there is no beds available in the ward or in the ICU, sometimes the emergency department, even if they don't want to, they might have to hold on to these patients. All right, till a bed is made available in the ward in the ICU. Okay, that's why discharging or disposing these patients early in the morning from the wards or in the ICU, moving these patients from the ICU to the ward early in the morning itself is very important. Because if you wait till evening for these discharges to happen, from morning till evening, all the admissions, they will get logged in the emergency department itself. All right. Just because you're waiting for a bed, unnecessarily patients are being kept in the emergency department, which again leads to overcrowding there. Okay. Now, emergency medical services is also part of the responsibility of the emergency department. Emergency medical services include pre-hospital care as well as inter-hospital transport. Okay, this is something which you have to remember. All right, because even if you are referring a patient to another hospital, it is your responsibility legally to make sure that the patient reaches the other hospital safely. Okay, so you need to provide adequate emergency medical services, which include ambulances, trained staff. Sometimes even the doctor might have to go with the patient till the patient reaches the other hospital. All right. So emergency medical services is also an important responsibility of the emergency department. Then you'll be becoming part of the code blue team, which will take care of cardiac arrest in the other departments, then a rapid response team. And if you're working in a private hospital, doing your residency in a private hospital, billing is also very important. All right. In government hospitals, the majority of the treatments will be free of cost. But in private hospitals, you need to consider the financial capability of many of these patients as well, right? So you cannot do all the investigations from the emergency department itself. You need to think about whether all these which are the most appropriate investigations to make from the emergency department, okay, especially to rule out life threatening conditions. All right. And all the investigations may not have to be done from the emergency department itself. All right. Because billing is a major factor. Okay. And many of the insurance companies may not provide uh, coverage for the treatment given in the emergency department. Okay, so that's also a major problem. Many of the companies provide uh, reimbursement only for the care which has been provided after admission. Okay, so you have to be extremely careful and considerate regarding the financial capabilities of the patients coming to your emergency department. All right. And all these responsibilities have to be fulfilled in a framework of customer service. This is something which we always lack, especially in the government medical colleges. We always assume things and taken things for granted, but customer service is very important. uh, I don't like to say it, but we are in the business of customer service, okay, because patient satisfaction, bystander satisfaction is extremely important, especially when you're practicing in a private hospital. Okay, so you need to start practicing how to communicate with the patients, how to communicate with the bystanders, and their satisfaction is also important from a treatment point of view. They will listen to you properly, they will be much more compliant with the treatment, and you will also be satisfied only if the patient as well as the bystanders are satisfied. Okay, so customer service is something which you need to learn during your residency itself. Okay, so these are the important things which I wanted to cover during your residency program and your postings, your rotations in the emergency department as well as in the ICU. All right. Always have a good rapport with other departments working in the emergency department. See, we are a team. All right. We have our final goal is to take care of our patients. All right. It doesn't matter whether the patient is admitted under medicine or admitted under surgery. It's always a patient under our hospital. All right. You have to think like that. You are just part of the team. Okay, but the problem is that many of these departments are having problems with each other. Many of these things are personal problems between the faculty, and it's the responsibility of the faculty to have good relations with other departments. Then only the residents can enjoy the rotations in the other departments. All right. And with that, I'll wind up this session. Uh, and so I just want to summarize that your rotations in the emergency department and ICU are extremely important. Doesn't matter if you want to go to critical care specialty or some other these are skills as well as knowledge which every doctor should acquire, even during the, and it should have started during your undergraduate days itself, but unfortunately it's not happening. But at least during your residency, emergency care should be uh, in there in your training. All right. Okay, so with that, I'll wind up this session. Thank you so much for patiently listening. I wish all of you all the very best. Good night.
Thank you, sir.